Okay. Assalamu alaikum everyone. I'm Salma Nusair. I'm a second year medical student. With me today is
Aylin, also a second year medical student, and we're very, very excited to start this physio practice questions with you guys because we kind of made it in a way where it's like we explained the important things that you need to have on top of your head. So when you go to the exam, you're just like spot on, you know what you're doing.
yeah,
Inshallah.
it's kind of a crash course, but not really a crash course. And we tried to have it like it's not just questions. A lot of parts are just us explaining. Inshallah this would be a good review.
But not the
Hopefully.
boring explanation, the explanation where it's like very fast, you just get it and khalas.
Yeah, like
Inshallah.
it's not we're not gonna go into details. And obviously, a lot of this we left out the recall, the just passive recall parts because there's no explanation there. So you do still need to do some memorizing, like for equations, for just different parts. Okay? Okay, just get into it. Our theme today is just gonna be Fireboy and Water Girl, and I'm red for Fireboy.
She's red, but she's cold, so
Yeah,
yeah.
had to
I'm
try.
blue for water girl.
And these are kind of the concepts. We kind of just grouped them into 7 concepts. Like there are 12 lectures, yes, but we grouped the similar ones together. So like structure is architecture,
Clearance and balances, filtration and flow.
and then tubular functions is just tubular functions. And then there are 2 lectures, one on concentration and dilution, and then the second one's on ECF, ICF. So we just put these 2 into one chapter, which is water and ion balances.
And acid base, there were 3 lectures, and we grouped them into like one concept, inshallah.
And then the last one, just bladder and mictuition, which is the Dr. Abdul Ahad lecture.
Yes.
Okay, so let's just get into it. Okay, so the kidney, as we know, is divided into medulla and a cortex. Okay, and this is shown here, where this is your cortex, and both of these are your medulla, which is split into an outer medulla and an inner medulla. Not really relevant for us now. This is more anatomy. In your cortex, you have the proximal tubule. One very important part of the proximal tubule is that the bulk of reabsorption happens there. How do you remember this? Okay, basically, the proximal tubule is very rich in mitochondria. What does mitochondria do? Mitochondria is the powerhouse of the cell, which means it generates energy. And this energy is used for active transport. Okay, so a lot of active transport takes place in the proximal tubule in the cortex. You don't need to know about the fact that it's in the cortex, but just know that in the proximal tubule. Okay? Another thing that the proximal tubule has is you see these little brush things. These brush things are called they're microvilli. It's a brush border. The point of this is to increase surface area. Okay? If you have more surface area, okay, these the brush border looks like this. But if I just took this brush border and I extended it, it would be really long. Like the surface area could be tenfold larger. Okay, so this brush border increases surface area, which allows for even more reabsorption. Another thing is that in between the cells, the junctions are very leaky, which means that solutes can very easily diffuse through these junctions. Okay, so proximal tubule, the most important thing about it is that the bulk of reabsorption happens in the proximal tubule. The second part is the descending loop of Henle. The descending loop of Henle is where you have your passive transport. Okay? And at this point, okay, it's transport, not just reabsorption, because you have حتى in the proximal tubule, you have both reabsorption, which is where the contents of the tubular fluid are being taken back into the blood and into the body, and you also have secretion, which is where you're removing the solute or the liquid or whatever it is, you're removing it from the blood back and into the tubular fluid. So you're removing it from your body. Okay, so it's not just reabsorption, it's everything, it's transport. Okay, so passive transport mostly in the descending loop. And how do I remember this? Passive transport is down the concentration gradient. So descending for down the concentration gradient. On the other hand, the ascending loop, which is split into 2 parts, the thin and the thick. Okay, they both have active transport, and A for ascending, A for active. Another really important thing that you should know is that the descending loop is where a lot of your concentration happens. So as you go down the ascending loop, water is being reabsorbed. So you're moving water from the tubular fluid and into the body, or into the blood and back to the body. Okay, so you're decreasing the amount of water in the tubule, but you're not moving any electrolytes. You're just removing water. What this is doing is it's concentrating it. Okay, and then as you move back up, you're diluting it. It's the other way around. It's impermeable to water, but electrolytes and salts can come, depending on the segment and depending on the electrolyte and salt, obviously. But essentially, the ascending loop is where you have dilution, especially the thick ascending loop. Okay? Here, electrolytes and salts can be reabsorbed, whereas water does not move. Okay? What's the point of all of this? Why are we diluting? Why are we concentrating and then diluting? We're doing this so that we have a concentration gradient over here. Okay, so that we have, it's called the medullary gradient, concentration gradient. The whole point of this is to allow water to be able to be absorbed, reabsorbed, or secreted more easily and passively. Okay, if you don't have this concentration gradient, you can't have any passive transport of the water. Okay, which is going to happen here in the distal tubule. Now, the distal tubule and the collecting ducts are both affected by hormones, okay? And essentially, the distal tubule is where a lot of the acid-base balances have, and they have two types of cells, the principal cells and the intercalated cells, okay? And the collecting duct is essentially, okay, it doesn't show here, but then you have one collecting duct and a bunch of distal tubules are attaching to it. So this is one distal tubule going into the collecting duct. Here would be a second distal tubule, another distal tubule, another, no, no, no. And then another really important concept when it comes to the kidneys is pressure. Because you have two compartments. You have the renal tubular fluid and you have the blood, or we're just going to call this the body compartment, okay? And you want things to move from the blood into the renal tubular fluid. You can do this actively, or you can do this by essentially just pushing it using pressure, okay? So how is this pressure maintained? Okay, you need to push it from the blood into the tubular fluid. How do you do this? You make a really high pressure here, which is going to push the solvents, the solutes, everything into the tubular fluid, okay? How is this pressure maintained? You have, firstly, that this blood is coming from the abdominal aorta, which is a really big aorta, and just has a really high pressure, okay? Just know that because it comes from the abdominal aorta, from the interlobar artery, whatever, just abdominal aorta, big artery, big pressure, okay? And the glomerulus is actually between two arterioles rather than an arteriole and a venule. Okay? Now, why does this matter? Why do we care? Because arterioles are known for being more resistant, for being they have higher pressure. Okay? They're they're thicker than the venules and they exert more pressure. Okay? So the fact that it's between two arterioles just means that it takes a lot of for it to get into the glomerulus, if it wants to go back out, it needs to go against a lot of pressure. And if it wants to go out of the efferent, I'm going to say afferent and efferent just for clarity. If it wants to go out of the efferent, it has to also go against a lot of pressure. So it's if you have to go a lot of pressure to go back, or if you have to go through a lot of pressure to go out, whereas if it would be easier if you just went into the tubular fluid. Okay, essentially the whole point is you're building pressure on either ends to force the fluid into the tubule. Okay, into the renal tubule. And then another really important thing is that the efferent tubule, the efferent arteriole, sorry, is significantly smaller and narrower than the afferent one. Okay? But why do we care? It's because this efferent one, the fact that it's smaller means that there's higher pressure. Okay? So for the blood to be able to go through the afferent one into the glomerulus and out, it has to go through a lot, and there's a lot of pressure to overcome. Okay? So if you think of it as a balloon. You have like a tube, then you have a balloon, and you have another tube. Okay? If there's a lot of pressure here and a lot of pressure here, and you're just pumping water, where's the water going to go? It's going to go into the balloon. Okay? The balloon's going to blow up. Think of the balloon blowing up as just filtration. Okay? And then if I increase the pressure here, by decrease the pressure here. So a lot of blood, a lot of the water is just going to go through the tube, through the balloon and out, since there isn't a lot of pressure here. However, in our case, there's less pressure here, way less pressure here, and more pressure there, okay? So the water is going to go through here, and it's going to go through the tube, the afferent arteriole, and it's going to go into the glomerular capsules, just going to the glomerulus, and then it's going to try to go out through the efferent one, but it's a lot smaller, a lot narrower, there's a lot more pressure. So rather than it just going out, it's going to blow up the balloon, and it's going to be filtered. Okay, so controlling the afferent and the efferent one is what's going to control your GFR. You dilate the first one, and you constrict this one, you're going to cause more filtration, because the water is going to have no problem getting into the glomerulus, but it's going to have a problem getting out. So it's just going to get filtered out. However, if I constrict the afferent one and I relax the efferent one, then the blood's going to have a hard time getting into the glomerulus in the first place, and it's going to go out way easier. Okay? I hope this made sense. And then the last part is the macula densa. Aylin's going to be talking about this later, inshallah. And it's just for autoregulation. Macula densa is essentially a sensor. It senses sodium and water and stretch, essentially. Okay? And this is what it looks like. This is your afferent and your efferent. This is what I was talking about. This is the macula densa. This is the extraglomerular mesangial cells. This is essentially more of anatomy. I don't want to go into too much details. And I'm going to talk about two things, though. Adenosine and angiotensin 2. They both act on the arterioles. However, angiotensin acts on the efferent one only. And whereas adenosine acts on both, but it has an opposing effect. Okay? Adenosine is going to constrict the afferent one, and it's going to dilate the efferent one. What is this going to do? the blood's gonna have a hard time getting into the glomerulus. It's gonna have no problem getting out. So what this is gonna do is gonna decrease GFR. Okay, so adenosine, you use it when you want to decrease GFR, whereas angiotensin, which is a vasopressin, is just gonna cause constriction and it's gonna increase GFR. Okay? Okay. Now on to the questions. You guys feel free to unmute or use the chat box, whichever one you feel more comfortable with. Would anyone like to read the question? Okay. Match the following nephron structures with their primary functions. It could be two. Okay. Okay, so one person said one is C. Okay, so everyone has a different answer. Would anyone like to unmute and kind of share their thought process with us? Okay. Okay. So the correct answer is actually B, C, D, A. So, like we said, the proximal tubule, we said it's leaky, it has a brush border and a lot of mitochondria. So the brush border and it being leaky. 3 is D, but it's more in the collecting duct. Yeah, it's both of them essentially. They're both for fine tuning. Okay. Proximal tubule is where the bulk of the reabsorption happens. It's because you have leaky, like the junctions between the cells are leaky, so molecules can pass more easily. You've got a brush border, so more surface area for reabsorption, and then ATP for the active transport. And then you have the ascending loop for active transport, like I said, A for active. Distal tubule is one of the last things, so it's fine tuning and reabsorption and acid-base balance. This could be distal tubule and to some extent the collecting duct. And then descending loop is where you have the passive transport, which is down the concentration gradient, not against it. Okay. Renal blood flow is unique compared to most other organs, which of the following is a distinguishable feature of renal circulation? Yes, Hannah, you're right. It's A. It has two capillaries. Would anyone like to try and tell us what the two capillaries are? Yes, these are the two arterioles. Yep, the peritubular and the glomerular. هلا you have two capillaries. You have the glomerular capillary and you have the peritubular, which is this one. Okay. There's also two types of nephrons. There's the medullary and there's the juxtaglomerular. I'm not gonna talk about this now, but this one, this area, is called the peritubular capillary bed, which is where all the reabsorption around the loop of Henle happens. And then this is the glomerular capillary bed. So you have two capillary beds, which is just arteriole, and then here you have arteriole to venule. Okay, does this make sense? Yes, Hannah, you're correct. Would anyone like to try this one? You're correct. It's B. Would you like to try to explain why? Yep. So the autoregulation, essentially, it's when the body or when the vessel, it feels like it was too relaxed, there's too many things happening. Okay, this is the vessel. If there was too much blood in it, it's gonna stretch a lot. Okay, this increased stretch is gonna cause it to constrict, to kind of accommodate or compensate for the increased pressure. However, if you had too little pressure, or these things, the capillary, the Prior mechanism is myogenic response, then TGF feedback. Yes. Okay, you all get it. But essentially, it's just if there's too much stretch, the arteriole is gonna make up for it and constrict. If there's too little pressure, that means that there isn't enough blood flow through the arteriole, so it's gonna relax more to kind of make more area and allow for more blood to pass through. Okay. Would anyone like to tell me what each of these would cause? Or why the other options are incorrect, yani? What would increased angiotensin 1 do? Yes, it would increase GFR. And how does this affect the pressure, the blood pressure? It increases. I mean, it happens through an increase in the pressure of the renal blood flow. And what would constriction of the efferent arteriole by adenosine cause? Or what would it do? Exactly, you're correct. It does not cause the constriction of the efferent arteriole. It actually causes the dilation. So this is why aslan C altogether is wrong. So you cross it out. And what would D do? D would actually make things worse. D would cause, if you dilate the afferent, increase pressure, not decrease. What do you mean? Oh, yeah. Yes. It would increase the pressure. It would make it worse because if you dilate the afferent arteriole, then you're going to be filtering out less. And lastly, for P1, would anyone else like to try answering? Correct. It's B. A 65-year-old hypertensive patient takes ibuprofen for chronic back pain. He develops oliguria. Does anyone know what oliguria is? Yes, it's decreased urine output. And which mechanism explains the reduction in renal blood flow? Increased prostaglandin synthesis. What would that do? Does anyone know what prostaglandin does to the kidney? Okay, and then why would you cross out A? I don't know if you guys know this, but ibuprofen is a non-steroidal anti-inflammatory. What these do is they decrease prostaglandin synthesis, so that's why you cross out A. And what about C? C is just unrelated because angiotensin 2 and ibuprofen, they just, like, there's no link between them. And then nitric oxide would actually, once again, is just not related to the ibuprofen. Okay, that's it for my part. This is Aylin's part now.
Okay, hi guys. First of all, I'm very happy you guys are answering and I'm excited to start.
Was enough,
So,
Roger?
so let's just start off strong with this. I'm going to read it and then you guys can answer the same way you're doing with Salma. In a renal function study, substance Z is infused into an experimental animal. The following measurements are taken: urine flow rate, which was 2 milliliters per minute, GFR, which was 100 milliliters per minute, afferent to arterial concentration of Z was 40 milligrams, and renal vein concentration of Z was 40 milligrams. What can you conclude about substance Z? I'm not gonna read the options. You can just read it too. Just pay attention to the important numbers because sometimes they just give you random numbers that you don't even need. Okay, someone said A. Why do you think it's A? Oh, it's not A. Ooh, someone's on the right track. Okay, Hannah, why is it C? Okay, so the answer is C, but can you tell me why? Okay, it's C because first of all, there's so many numbers that you don't even need. They're asking you about substance Z, and based on the options, you just have to know. You just have to look at. Yeah, exactly. It didn't mention it being secreted or reabsorbed, and you can also tell by the numbers. Because in the afferent arterial, the concentration was 40, and then in the renal vein, the concentration was also 40. What does this tell you? And the afferent is when before it reaches the kidney, okay? And then renal vein concentration just tells you about the concentration that was filtered. So it was 40. It was exactly the same as the afferent arteriole. And if it was, for example, a number higher, that means that it was reabsorbed. Like it was filtered and then it was reabsorbed. It was sent back, or like the difference in the number can tell you if it was reabsorbed or secreted. Like if you got a higher number in the renal vein, that means it was secreted. This means that it's not completely reabsorbed. It's not reabsorbed at all. Like in this question, the substance was not reabsorbed at all. It was just filtered and it didn't get sent back to the blood. Is this clear? You can just apply this, like, just look at the numbers and see them in your head, okay? Sometimes they give you afferent and efferent, okay? Which tells you efferent, for example, if the efferent, they're going to tell you it's probably zero because it was all, خلاص, it was all sent to the, like, filtered. It's all sent, خلاص, it's going to go as urine because it wasn't reabsorbed. Okay, I'm going to move on to the next question. A patient has the following data: plasma concentration of substance A. It is not clear, so, wait, let me go back. Why not E? I mean, E is correct, but then their venous artery side. What does that mean? If they tell you afferent arteriole, it's the one before it was filtered, and then efferent is the one after it was after it being filtered. And Hannah, it's not E because um you can't just say no, it was not filtered nor secreted, because what can you conclude? You can conclude what do you mean it's not filtered? Because in the concentration in the renal vein is 40. That means it was filtered. If it was not filtered, it would have been zero. Like you would get nothing in the renal vein. Just because the word renal just tells you the fact that it was sent to the kidneys. If it was vein concentration, you'd think this is your systemic and it's not your renal vein. Is that clear? Just because you said renal, that okay. No worries. Okay, a patient has the following data: plasma concentration of substance A, which is 2 milligrams per milliliter, urine concentration of substance A, which is 20 milligrams per milliliter, urine flow rate, which is 1 milligrams per milliliter. What is the renal clearance of substance A? It's just an equation question. Just plug in the values. Okay. Someone's saying A. Okay, honestly, I'm not going to spend too much time on this because it's just the equation. But this is, I just wrote for you the formula. Basically, what is clearance? Clearance refers to the volume of plasma from which a substance is completely removed by the kidneys. So, for example, the substance is in the blood. Clearance refers to how much it was removed, how much it was cleared from the blood. So, this is just the equation. Just plug in the numbers. Clearance equals concentration of the substance in the urine multiplied by the rate of urine formation divided by the concentration in the plasma. Is this clear? Okay. A patient is infused with inulin to measure GFR. The following results are recorded. Plasma inulin concentration is 2 milligrams per milliliter. Urine inulin concentration is 150. Urine flow rate is 2 milliliters. Plasma concentration of substance X is 4. What is the filtered load of substance X? There's a trick here, guys. And if someone gets it, wallah, you're getting an A in your renal, inshallah. Guys. Where are you guys? Just throw in a number. Okay, I'm gonna explain this. Okay, first of all, the trick that I wanted you guys to catch here is that we didn't give you the GFR. Because why? We gave you inulin concentration. And based on what you guys studied, inulin filtration or inulin is equal to GFR. So they can trick you with that. Like for example, PAH is equal to renal plasma flow. They cannot give you renal plasma flow, but they can give you PAH. And you're supposed to know. So here, inulin, first of all, I'm going to go to the equation I wrote here for you guys. They're asking for the filtered load, okay? Filtered load is, where is it? GFR times PX, which is plasma concentration, okay? Plasma concentration of the substance. So the first step is to find GFR. GFR is the urine concentration of inulin times the urine flow divided by plasma concentration of inulin. So after doing this and plugging in the numbers, you get 150 times 2 divided by 3, which is 100, okay? That's GFR. And then for filtered load is GFR times plasma concentration. And here we got GFR, which is 100. And what is the plasma concentration? They gave it to you, which is 4. So the answer is 400. Do you guys get it? Like, they didn't give you GFR right away. They just gave you information about inulin. But you know that inulin is equal to GFR. I'm going to explain this in a diagram when we're moving on. But for now, do you get this? Is it clear? Do you guys have any questions? Okay, perfect. Thank you. Moving on. This is just the equation. You guys can use it as a reference. It has literally everything, okay? For anything you need, you're going to find it here in this equation. Okay. The clearance of which substance equals the effective renal plasma flow? I just said this. Ooh. Ana, mashallah. It No, who said A? Inulin is GFR. This is not GFR. This is renal plasma. Yeah. Inulin is GFR and renal plasma flow is like they're two different things. I'll explain them in a bit. Just okay. So it's PAH. They're equal. Okay. Here is where I'm gonna explain everything. Okay. Okay. Listen. First of all, you guys can see. You literally just said PAH. What do you mean? I said PAH is equal to R. PF, and inulin is equal to GFR. I'm going to explain it here. You guys can see my pointers, huh? Okay. So this is the afferent arteriole, this is the afferent, and this is where the glomerulus, where things are getting filtered, okay? So here we have filtration only. The substance is getting filtered. You don't see any arrows going back to the blood or arrows going back to the tubule, okay? So this is the GFR, without any reabsorption, without any excretion. And what did I just say? That inulin is equal to GFR. So sometimes they can give you GFR, but they mean inulin. Sometimes they can give you the opposite. So filtration only means there's no reabsorption and no secretion. And then for filtration and partial reabsorption, things are getting filtered into the tubule, but then they're getting reabsorbed. Some of the content is going back to the blood. Okay, and an example, this I don't know how important this one is, but it was mentioned in your slides, so I'm just gonna mention it. What I know is really important is inulin and PAH. Okay, urea gets filtered, but some of it gets back into the blood, so it's partial reabsorption. And then another example of reabsorption, but complete reabsorption, is glucose. We know that you cannot have glucose in your urine at all. If you do, then there's a problem in your kidneys, there's a problem in filtration, reabsorption. For an example of something that's filtered, but then completely reabsorbed, is glucose. Because you do not want glucose to be secreted into your urine, right? You don't want that. It's you need glucose, and there's other mechanisms of excreting it, but in the urine you're not supposed to find glucose. Even the smallest concentrations indicates that there's a big problem. Okay, so this one, filtration and secretion, means that it was filtered, but then some of the concentration that was in the blood is getting secreted even more. Like we want to secrete this as much as we can, but this is here it's supposed to say partial secretion because we have full secretion here, but partial secretion. Okay, and then for creatinine, you do not want creatinine in your blood. You want it all to go in your urine, so there's complete secretion. It's getting filtered and then it's getting secreted, like all of it. You see there's nothing in the blood anymore. Is this clear? I think the most important thing you have to know is that glucose is not supposed to be found in the urine, and that inulin is equal to GFR and PAH is equal to RPF. And then here there's the renal equation: amount filtered plus amount secreted minus amount reabsorbed equal to amount excreted. So what's the difference between secretion and excretion? Excretion is خلاص, it's excreted from your body. Okay, and then secretion is just the process of a substance being secreted from the blood to the tubules. Okay, so you filter something out, and then you want to know how much of it is excreted. يعني خلاص, it's out of your body. You add the things that are getting sent from the blood to the tubule, so it's a secreted amount. And then some things they don't just go into the urine, they get reabsorbed, so you have to subtract them. Just honestly, I don't really like using equations because we're not in math class, but like just think about it logically. Something filtered and then it went back to the blood. That means it wasn't sent out. يعني خلاص, it's not excreted. So you minus it from the filtered amount, you know? Is it clear? It's really important, guys. And note here that it's partial secretion. Can I relate it back to the question? I mean, I put this not for the question, I put this just for the concept. But what question are you talking about? I can go back. This one? Okay. Here I said that renal plasma flow is equal to pH. What is renal plasma flow? It's just the flow. You're asking about this, yeah. So we said that it's pH and not glucose, and not creatinine, not urea, not inulin, because pH is filtered and secreted, but not fully secreted. If it was fully secreted, then we won't count it as renal plasma flow. It's partially secreted and barely even secreted. So renal plasma flow is just the flow of blood that goes in like this, and then it goes out with the normal filtration, because almost everything gets filtered. But then your kidneys have mechanisms in which they say, no, oh, I want this to be excreted and I don't want this to be excreted. So that's why we measure the renal plasma flow in the efferent arteriole, like here. As you can see here, for example, here when it's reabsorbed, you get an increase in the renal plasma flow. But here, because I forgot to put partial, but by partial, for secretion, especially for PAH, it's very minimal secretion. So it's like almost equal, okay? Okay, let's move on. A patient presents with dehydration. Based on this condition, what would you expect their free water clearance to be? If you're dehydrated, what would your body do? What's the mechanism? Yay! It is C. I think it's self-evident, like when you're dehydrated, your body's gonna try as much as possible to just reabsorb the water. So when you reabsorb water, you're gonna excrete less water, and the concentration of your urine is gonna increase because you're dehydrated. Okay? Is this clear? I think this is really clear. I hope to get you a question like this because it's easy. Okay. What component of the glomerular filtration membrane prevents the passage of large negatively charged molecules like plasma proteins? Okay, someone said C. Why? Okay, so it is the basement membrane, because the basement membrane has negatively charged components, and negative they repel. Okay, so it doesn't allow the passage of the charged molecules, the negatively charged molecules, because they're just, yes, exactly, the basement membrane is negative. Okay, I think we're reaching towards the end of my part. Which of the following will increase glomerular filtration rate? Ooh, someone's fast. Okay, Dana said A. Why? What does the filtration coefficient depend on? Yeah, it is from the equation, but like in a concept-wise. Okay, it is A, and if you want to think about it in a like conceptually, the filtration coefficient depends on the permeability of the glomerular membrane and the surface area. So when you increase the filtration coefficient, that means you're allowing more things to be filtered. So evidently, it's going to increase the filtration rate. Okay, I'm going to talk about these stirring pressures inshallah, in a bit. A drug that dilutes the afferent arteriole will most likely cause, to dilutes, dilates. Sorry. Come on, guys, it's really easy. Oh, mashallah, Dana. Okay, does anyone have any other opinion? Dana said B. Okay, why is it B? Okay, B. Okay. It's B because obviously when you dilate the arteriole, basically you're giving it more space, you're giving more space for blood to come in. It's just gonna increase the filtration rate and the renal blood flow. Because There's just more blood. That's exactly it. And it would be the opposite if it says constricts. And if you constrict the arteriole, less blood is going to come in, so less things being filtered and less like amount of like things going inside the tubule. Okay, this is my last question. Which of the following changes in starting forces would most directly promote an increase in GFR? A, B. Well, was this from the question? I think, yeah. Is it C? Why is it C and why is it B? Why? Okay, it is either B or C. So can someone convince me why it's either? It's not A, it's not D. Isn't Bowman's capsule increase oncotic pressures attract water to Bowman, so increase filtration? Okay, the answer is C, and let me explain to you why. I'm going to explain the entire thing, because if you understand it, I think you're set for the lecture. So here, it's C, decreased glomerular oncotic pressure, because what does the oncotic pressure do? It pulls fluid back into the blood, okay? So we're saying that you want to increase the GFR. That means we want to increase things being sent back to the blood. So when you're decreasing or you're pulling less fluid back into the blood, you're gonna have more concentration, more substance in the tubule. Like you might have gotten confused because there's so many decrease and increase, but when you're glomerular oncotic pressure pulls fluid back into the blood, okay? And when you're pulling less fluid back into the blood, you're having more fluid inside the tubule. So it's gonna increase the glomerular filtration rates. Is this clear? Because I'm gonna go and like explain the four of them. What is B wrong? Increase Bowman's capsule oncotic pressure. Okay, what does Bowman's capsule oncotic pressure do? It promotes filtration if protein present. Promotes filtration if protein present. Increase. Okay, it's not B because we don't know the concentration of proteins. They could be. Did someone say no? The proteins they're zero. The pressure is zero, so it doesn't really change. I remember from renal where the doctor, I think she mentioned that this is the coefficient that just doesn't change. You know, but you're not gonna say no. Oh, increase Bowman's capsule oncotic pressure. It just doesn't change. It's always zero. So you're gonna go on something more reliable, which is the glomerular oncotic pressure. It's negligible, exactly. Don't consider it. Okay. Yes, the equation shows it, inshallah. Okay. So for this concept, okay, the pressures, last year, I remember I struggled with this so much, but then it's really easy once you get it. So we have four pressures. Pressure that's in the blood and pressure in the tubule, in the glomerular tubule, okay? Two pressures in the blood and two pressures in the tubule. The two pressures in the blood, one wants things to go out of the blood, one wants things to go back into the blood. It pushes things in. And the same thing for the tubule. A pressure wants things to go in the tubule, and another pressure that wants things to leave the tubule, okay? So first force or pressure that we have is the glomerular hydrostatic pressure. What it does is that it pushes fluid out into the kidney. So this is the pressure that's in the blood that wants the fluid to go into the tubule. You want it to be filtered. Okay? And then the opposite here, you have oncotic pressure. You don't want it to be filtered. You want it to go back to the blood. Okay? And whenever you think about, yeah, okay. And then Bowman's capsule pressure, it pushes fluid back into the glomerulus. It is the pressure that wants the fluid to go into the kidney. And then the opposite, you have the, is it clear so far? I don't want to confuse you guys. This is the negligible one, so just don't think about it, okay? Bowman's capsule oncotic pressure. Clear, thank you, okay. Okay, this is it for my part, but we're gonna have a prayer break for 10 minutes. So, inshallah, after 10 minutes, we'll come back and Salma will start her part. Salma says bye, and I glomerular. Okay, how does the tubuloglomerular feedback mechanism regulate GFR? Oh my God, people left. That's so sad.
Maybe they're still praying.
I hope so. Okay, the answer is B, and I feel like this is the most important thing your doctor focused on in terms of regulation. Macula densa in the distal tubule senses sodium levels and adjusts afferent arteriolar tone. So the tubuloglomerular feedback mechanism in GFR regulation is basically when the macula densa senses the solutes, which is like NaCl concentration. So when there's a lot of NaCl delivery to the macula densa, because of why? There's more filtration, more GFR. This triggers adenosine release, causing afferent arteriole constriction to reduce GFR. So when you have a lot of GFR, it's clear that you're going to have more NaCl getting filtered. So the macula densa is going to sense this, and it's going to trigger adenosine release. And adenosine release, what does it do? It constricts the afferent arteriole, which decreases GFR, which decreases NaCl. Okay, this is really important for your blood pressure. And the opposite is true. If the macula densa senses that there's low NaCl, it's gonna be like, oh, there's less GFR. So what is it gonna do? It's gonna signal renal release, and it dilates the afferent arteriole, which increases GFR. Okay, so this is the most important thing in terms of regulation. So yeah, that's it for my part. And now Selma's gonna move on to her questions. Do you guys have any questions? Okay, خلاص.
Okay. Assalamu alaikum, guys. And for the sake of time, because I realized we were taking a bit too long, we're gonna kind of try to speed things up. Okay? For starters, wait, I wanna draw. I wanna explain a concept which I'm sure most of you know from high school, which is just concentration. Okay? Concentration depends on two things, the solvent and the solute, right? So wherever you have more, okay, in our case or in the body in general, the water is the most common solvent, which is where things are being dissolved essentially. Okay, so compare these two glasses, this one, number one, and this one, number two. Okay, even though you have the same number of particles here or the same number of solutes, the concentration here is higher. Why? Because concentration depends on the amount of solute, sorry, over the amount of solvent, which in our case is water. Okay, so wherever, wait, sorry. Okay, so wherever can you guys see my writing, by the way? You can, صح? Yes. Okay. If by the way, if at any point you're confused or just something doesn't make sense, please feel free to stop me. Okay, I'll keep going. So I was saying, solute and solvent. So even if you can't actually move the solvent, even if you can't change its amount, if the solute, sorry, changing the solvent's amount will change concentration. Okay. So in our case, in this example, all we did was move the water. All we did was move the water molecules. Okay? What this did is it increased the concentration. Does this make sense? Because if you have it just solute over solvent, if this is your equation, you can make it bigger or smaller either by changing, this is just basic maths, either by changing the numerator or the denominator. Okay? So the denominator is inversely related. So if you increase the amount of solvent, you decrease concentration. If you decrease the amount of solvent, you increase concentration. Does this make sense? Okay, I'm going to move on. So what is TF over P? TF over P is just tubular fluid over plasma. What this is you're comparing the concentration of the substance, whatever it is, in the tubular fluid and in the plasma. Let's just think about this again. Imagine that this is your glomerulus and this is your blood vessel. Okay? If you have a higher concentration in the tubular fluid as opposed to the plasma, this means your TF is greater than your P. So if your TF, wait, let me just clear the drawings. Okay, we said that in this case, your TF is greater than your P, right? In this case, would this number be smaller, equal to, or greater than 1? It would be greater than 1. Okay? However, let's try it again. If the concentration of the substance in the tubular fluid was less than that in plasma, then your TF over P is going to be less than 1. Okay? And if they're the exact same, that means that they're going to be, that your TF over P is going to be equal to 1. Okay? Why does this matter? We're going to see in the next question. Also, one thing, the reason I started explaining the solvent solute is sometimes you can't actually change the amount of solvent. Okay? So in this case, for example, TF over P, would it be greater than or less than 1? Assuming this is TF and this is P. Would it be greater than or less than 1? It would be less than 1. However, this is assuming that the amount of water in both the tubular fluid and the plasma is the same. However, if all I did was just, let me change the color. If my water molecules, if I had 1 water molecule here, as opposed to 1, 2, 3 water molecules here, this would mean that my P is actually greater than my TF. Okay? Basically, all this is saying is TF over P is the difference in the concentration in the tubular fluid versus the plasma. Okay? And this doesn't just depend on the amount of solvent in the of solute in the tubular fluid. It also depends on water. So if you have 2 compartments, okay, if the water is moving, regardless of whether or not the solvent is moving, okay, whether or not your solvent is moving, the movement of water could dictate or change the concentration of the solute. Does this make sense? I'm going to assume it does, and I'm going to move on. Okay? Based off of what I just explained, could someone try answering this question? Okay. I'm going to read it out loud just for the sake of time. A researcher measures the TF over P ratio of 2 substances at the end of the proximal tubule. Substance X has a TF over P of 1, and substance Y has a TF over P of 3. Which of the following conclusions could be made about these substances? I'm not going to read the options. It's either that way. You are correct. It's absorbed proportionally to the water. Why? How does this make sense? Let's just go back to this one. Because if in this, for example, let's look at this portion where all that's moving is the water. If I move the solute at the same rate as the water, then the concentration isn't changing. Because yes, I said it's solute over solvent. If I'm changing both of them at the same rate, then it's going to be 1. Because even if I have 3 over 3, or if I have 10 over 10, see, even since they're both changing at the same rate, it's always going to be 1. Okay? This is the case. Oh, actually, wait, this is the next question. Could you try answering this question? Correct. That's B. This is why TF over P is really important, because for sodium, it's reabsorbed at the same rate as water, especially in the proximal tubule. Aslan, the reabsorption of sodium or NaCl, mostly sodium, is what drives the water reabsorption. Okay? So TF over P for sodium should always be 1. Okay? There's other substances. Some substances would be secreted. Wait, I have a picture that would. No, I don't. Okay. Some substances would be secreted. Some substance would be excreted. I do have a picture. Okay. Okay, since you saw the answer, when you answer, I want you to explain it to me. A patient with severe uncontrolled diabetes mellitus is found to have a TF over P ratio of 4.5 for glucose at the end of the proximal tubule. What does this most likely indicate? You saw the answer, right? No. Okay, then try to try to answer it, I guess. Okay, since you got the answer right, could you tell me why? Could you try to explain it? Okay, wait. What makes you think that? Try to explain. Can you explain your reasoning? As increased glucose concentration, which receptors are not enough picking it up. Yes. And what about? I don't know who Dot is, so I'm just gonna call you Dot. Why do you think it's C? Okay, for the sake of time, I'm gonna move on, but it's actually B. The whole point of this is that if you wait, I'm gonna annotate. Okay, if you look.
Yeah, guys, what did I tell you? Glucose is all reabsorbed.
Exactly. So, just like Aylin said, too much glucose to be absorbed. Exactly. The transporters, they're overused. Like, imagine all you have. I'm gonna make the numbers way smaller. Obviously, in real life, they're way bigger. But let's just say you have four transporters. Okay? If you have 4 molecules of glucose, then all 4 of them would be reabsorbed. So you wouldn't have any in the urine. However, if I had 6 glucose molecules, then they're not gonna have anywhere to go. Because this one's gonna go with this one, this one's with this one, na. And then these 2, they're not gonna have anywhere to go. So they're just gonna stay in the urine. This is what's gonna give you glucosuria, or just glucose in the urine, which is abnormal. Okay? So 4.5 for glucose is really high. Normally, TF over P for glucose would be, what would it be? If I told you that normally all of glucose would be absorbed, what should the TF over P ratio for glucose normally be? It's actually 1. It's 1.
Yeah, but the concentration is 0, so maybe she got confused.
Anyway, we are not really, you don't actually need to know this, but just know that any ratio, anything more than 1 for, anything more than 1 for glucose, a TF over P for glucose is too high, because you shouldn't have any glucose in your urine. Anyone who's non-diabetic should not, like, their urine shouldn't be sweet. Okay? Moving on. This is just, I wanted to explain it. Let me clear the drawings. This is your glucose transporter. Okay? If it was overused, if it was overworked, okay, then all these glucose molecules just won't have anywhere to go. They're just gonna stay in the urine, and they're gonna stay in the tubular fluid, and they're gonna go out in the urine. Okay? And this is seen in diabetics because they have too much glucose in their body anyway. So the amount of glucose is high. Okay? Does this make sense so far? Okay. By the way, I'm skipping over these, but you will have the slides, inshallah. So you can just look at them if you're solving this on your own. Okay. Which of the following scenarios would result in increased water reabsorption via the paracellular pathway in the proximal tubule? Okay, I want you to think about this one, but fast because we're time. Okay, the answer is A. Why? Because water is reabsorbed. Okay, because water is normally reabsorbed passively, or you can kind of say through secondary active transport. Either way, it's just reabsorbed when, let me just annotate, you reabsorb water through a gradient. Okay, essentially, you have this NAK. Oh, wait, I'm not drawing. You have this NAK ATPase. Okay, what this ATPase does is it pumps sodium into the back into the blood. It reabsorbs sodium. Okay, so this is going to make a really high concentration of sodium here. And water loves sodium. So wherever sodium goes, water goes. Okay? So in a normal situation, this pump is working, you're pumping Na back into the blood, and water is following. However, if for whatever reason this pump wasn't there, then you're not gonna have sodium here. There's nothing. So water isn't gonna want to go there. Okay? So if on this is one extreme, and then the other extreme would be if you have too much activity of this. So if you have too much Na, there's just an overwhelming amount of sodium back in the blood. It's being reabsorbed like crazy, okay? Or like one of our doctors say, like there's no tomorrow, okay? What the water is going to do, it's going to want to it's going to want to compensate this increase in osmolarity, and it's going to want to go back with the sodium. So instead of just having a little bit of water, you're going to have a lot of water to compensate for the increased amount of sodium, for the excessive amount of sodium, okay? And then this one as well. Wait, let me open the chat box. Okay, I'm going to try to solve this one. Okay, once again, for the sake of time, the answer is actually C. I'm just gonna go through the process of elimination. Okay. A mutation in the sodium hydrogen exchanger in the proximal tubule impairs its function. Okay, so there's a mutation and you don't have the NaH. Okay, what is the most likely consequence? So, if you don't remember, this is the sodium hydrogen ATPase. It's on the apical membrane of the thing. Essentially, it's where the tubular fluid is. Okay, and this is where the blood is. So what it does is it pumps hydrogen into, let me clear. What this does is it pumps hydrogen into the tubule or into the urine. I'm just going to say this because it's easier. And it pumps sodium back. And where did we say the sodium does? The sodium goes back out and it creates a concentration here and then water follows. This is from the previous question. Okay? So this pumps hydrogen into the thing, back into the fluid, into the urine. Okay? So if you aren't pumping hydrogen into the urine, what would happen? Would you have increased bicarbonate reabsorption? No. I'll explain this now. Okay, basically, this is the whole pathway. First thing you have is the ATPase, the sodium hydrogen ATPase. You have sodium in, hydrogen out into the urine, okay? And then this hydrogen is gonna bind with HCO3 and it's gonna form H2CO3. This is gonna split into H2O and CO2. And then this CO2 is gonna diffuse through the membrane. Why? Because, wait, actually, let me finish. And then CO2 is gonna bind. It's this exact thing in reverse, okay? CO2 is going to bind with H2O, it's going to form H2CO3, and then it's going to split into hydrogen and HCO3. Why do we do all of this? Why this entire hassle? Since we're doing the exact same thing in reverse, it's because HCO3 cannot pass through the membrane. Okay, however, CO2 can. So what you're going to do is you're going to convert HCO3 into CO2 somehow through this pathway, and then CO2 is going to diffuse, and then CO2 is going to turn back into HCO3. Okay, and then HCO3 is going to go back into the bloodstream. HCO3 is basic, which means it causes metabolic alkalosis. In our case, the pump is not working, it's impaired. So you do not have reabsorption of HCO3, which means that you don't have any HCO3 going back into the bloodstream. This is going to cause acidosis, which is just you have acids, you have bases. If you have more acids than bases, then you're going to have acidosis. If you have more bases than acids, you're going to have alkalosis. Okay? In our case, we just assume there's a normal amount of H+. However, there's no base. There's no base, you're going to have acidosis. Okay? So, increased bicarbonate reabsorption, no. This is the exact opposite. That's why I cross it out. And metabolic alkalosis, once again, no. We said because it's exact opposite. You have decreased bicarbonate reabsorption, reduced sodium, reduced sodium reabsorption and respiratory alkalosis. How would it be alkalosis? Once again, we said it would be acidosis because you don't have this base being reabsorbed. This base is going out in the blood, it's going out in the urine. It's not going back into the body. One thing you should keep in mind when you're studying renal is that you have your body is one compartment and then you have the urine. Okay? Whatever leaves the urine is leaving your body. I know it sounds very obvious. Obviously, this happens, and whatever is leaving your body through the urine, whatever is leaving through the urine is leaving your body. But just I just realized it way later on, and I want you guys to realize it before it's too late. Okay? In our case, the base is not going back into the bloodstream, which means it's not going back into the body, which means it's not balancing out the acid, so you end up with acidosis. Does this make sense? Okay. And for the last option is just increased water reabsorption, hypervolemia. This has absolutely nothing to do with what we're talking about, so we just cross it out because it has nothing to do with it. And I think we explained why it's C. Moving on to the next question. Aldosterone acts on the principal cells in the late distal tubule and collecting duct to increase sodium reabsorption. Which transporter is directly upregulated? This is more like memorization than it is critical thinking. So there's not really much explanation here. Okay, so there's a few keywords here. You have aldosterone, you have distal tubule and collecting duct, and then you have directly and upregulated, obviously. So why is B wrong? For this one, just go through process of elimination. It's way easier. The NaH exchanger is not directly affected by aldosterone. Also, the NaH, which is the one we talked about right here, is in the PCT. Okay? And more importantly, it's not directly acted on by aldosterone. Like aldosterone doesn't directly act on this exchanger. Lastly, secondly, we have the sodium glucose transporter. This is in the proximal convoluted tubule and not the distal convoluted tubule. How can you memorize this? Because, like I said, most of glucose is meant to originally be reabsorbed early on. Like, you're not meant to have any glucose. Like, okay, the amount of glucose in the body normally is set, okay? And you have the right amount of, subhanAllah, you have the right amount of transporters in the proximal tubule, okay? So ideally, or in a normal situation, in a normal human, the glucose should never make it past the proximal tubule, proximal convoluted tubule, okay? That's why the glucose co-transporter is in the proximal convoluted tubule and not in the distal, it's not distally, it's not in the distal and collecting duct, okay? This should be collecting duct, sorry. And then lastly, the NAKCl transporter, this is in the thick ascending limb. This is actually the characteristic transporter, you could say, okay? I hope this makes sense, and I'm sorry if I'm speeding through it, it's just for the sake of time. This is the same exact thing I just explained, but then, once again. This is a table where I just wrote down, it doesn't cover everything, it covers just the main transporters where they are, and then you can cross-reference it with your lecture slides. But then yeah, this is just a table with the most, well not it's just the most important or the most common transporters, okay? Next question. Would anyone like to try? Okay. So this is essentially asking about, this a question like this is just asking about the effects of aldosterone, okay? Most of the times when you see excessive or impaired or whatever, all they're asking for is the function of this. In our case, we're asking about excessive aldosterone. This is pretty straightforward since it's excessive. It's just asking you, what does aldosterone do? Okay? Aldosterone, sorry, does two things. It increases H plus secretion and increases potassium secretion. This is just like your slides. This is the actual slide, but I found it really ugly. But essentially, this is what your slides say. Aldosterone increases the secretion of potassium and the secretion of H. Okay, what this means is, okay, you're secreting H. Secretion means you're removing it from your body. You're essentially excreting it through the urine. Okay, this is your renal tubule, this is your blood. You're secreting H and K plus into the renal tubule and out of the blood. Okay, so you're getting rid of H plus. Okay, you get H plus is an acid. You're getting rid of acid. What does this result in? It results in alkalosis. Okay, and then same thing for potassium. You have potassium. You're secreting it into the renal tubule. You're secreting it into the tubular lumen, into the urine. What does that mean? You have less potassium in your body, so you're gonna end up with hypokalemia. Okay, this is pretty straightforward. There's really not much to it. This is the end of this section. Now we're gonna move on to water and ion balance. This was honestly really, really fun when I did it. I remember last year, like just really fun. There's also a summary for this lecture. It's once again, it doesn't cover everything. It's just it helps you organize your thoughts and everything together. Okay? It's also color coded, so green for permeable, red for impermeable, and then dark purple for dark purple for concentrated, light purple for dilute, and then just this is a concept I found really cool last year. Wait. B, will you send this doc? Yes, it's on the slides. You have it. But if you have any problem reaching it, you have my contact. Like if you can't access it, you have my contact info. Just text me and I'll send it to you, inshallah. No worries. Okay. We finished 2 of my sections. Now we move on to the next part. Would you like to answer this one? I'll read it out. A patient with a genetic mutation has okay. This one I want you to actually take in every single word. Okay. I'm gonna help you cheat by emphasizing. A patient has a genetic mutation. Wait, a patient with a genetic mutation has impaired active transport of sodium in a specific nephron segment, leading to an inability to concentrate urine. What would you expect in this patient's urine composition? Okay. Before I actually saw this, I want you to pick up on just the keywords. Okay? It says active transport of sodium. Where do you have active transport of sodium? In which part of the nephron? Do you remember? Active transport of sodium. Hello, obviously this question could be answered with just inability to concentrate urine, but more importantly, I want you to focus on active transport of sodium. Okay? Where do you have active transport of sodium? In the thick ascending limb of where did the zoom go? Okay. You have thick. Okay. Active transport of sodium tells you it's the thick ascending limb. Okay? Thick ascending limb is where you are, it's where it's impermeable to water. Okay? So there's no water reabsorption. No. Okay? However, in this case, you can't transport Na. Okay, which means what did we say the most important thing about sodium in context of water is that it causes the gradient, which is what pulls water. Because water essentially can be reabsorbed or secreted in 2 ways, mostly through aquaporins or just paracellularly or passively through osmosis. Okay? Back to this question. We're talking about the thick ascending limb, which means that there's no water. Anyway, you can't concentrate urine, so you have hypotonic urine, high sodium because you are not reabsorbing urine. Okay? Did I have a picture? Yes. Okay. So this is the thick ascending limb, and you can't reabsorb sodium. Okay? You're not reabsorbing sodium, which means down the line. So this is the thick ascending limb, after which comes the distal tubule and the collecting duct, which distal tubule and collecting duct do to some extent allow water reabsorption, although not in great amounts. It's slightly permeable. But if you don't have this gradient, then you won't have any water absorption. This is one of the things that I talked about in, okay, I'm not going to open it, but this is one of the things I talked about in the document, which is just why, wait, I can't, okay, which is why we first dilute the urine, then we concentrate the urine, because this is, okay, this is just a summary real quick. This is your glomerulus, and then descending, ascending. Essentially, in this part, what you're doing is okay, wait. Okay, well, you can't see it. And then here's your blood vessel, okay? In this part, what you're doing is you're reabsorbing water, okay? You reabsorb water and only water because as we know, this part's not permeable to electrolytes or salts. What we're doing is you're reabsorbing water, so you're taking the water out of the tubular fluid. What this does is it concentrates it. So as you go down the descending limb, you're concentrating your fluid, your urine. And then as you go back up, what you're doing is you're taking out the electrolytes. Okay? You're taking out the electrolytes, but water is not moving anymore. Okay, so you have water, the amount of water here is fixed, but the amount of electrolytes is decreasing. So what you're doing is you're diluting it. Okay? So subhanAllah, subhanAllah, what this part is doing is you're creating a medullary gradient. Okay? So now here you're gonna have a lot of electrolytes and a lot of salts. What this is gonna do is it's gonna allow for later on down the line, you have the glomerular, I can never pronounce it, no, and then distal collecting tubule?
Tubule.
I forget. No, distal
Yeah.
collecting tubule, DCT and CD down the line, okay, where you have some fine tuning. If you did not have this concentration gradient, if you didn't have this gradient formed by the diluting segment, which is the thick ascending limb, then you would not be able to reabsorb water because water reabsorbs passively, okay? So, one concept real quick. As you go down here, you're concentrating it. And then as you go back up, you're diluting it. And then back here in this area, through ADH and other hormones, I'm not going to go to depth with this part, inshallah, Aylin will. You're just fine-tuning. You're reabsorbing. Never mind, I don't think Aylin was going to go through it. It's going to come up at some point, I think, but it's not here. What we're doing is just you're reabsorbing water or secreting it, depending on what you need. Okay? I think I just talked a lot for this part. Does anyone want to try this question? A nephron segment produces tubular fluid with osmolarity decreasing from 1,200 milliosmoles per liter to 100 milliosmoles per liter as it ascends. Which property of this segment explains this osmolarity change? I think I just explained this. Correct, it's A. Like I just said, you went from 1,200 to 100, which means you're in the diluting segment, which is the thick ascending thick ascending limb, which is a place where you don't have any water reabsorption, but you do have what's it called? Salt reabsorption. Okay. Notice here this is active because you're in the thick ascending loop. Okay. So keep in mind ascending loop active, descending loop passive, and descending loop is permeable to water. Ascending loop is permeable to salts and electrolytes, depending on thick or thin. Okay. Oh. Okay. I'm gonna skip this because I don't know what's happening. I'll come back to it later, inshallah. Okay. A patient with adrenal insufficiency is most likely to exhibit which of the following changes? Okay, this is everyone's favorite. This is the Darayanit. Okay. Obviously, I don't expect you to just know it like this because I never could solve it like this. I'd always draw the Darayanit. So I suggest you pull out a paper and you just draw it.
This is no one's favorite. She lied.
I genuinely loved this last year. This was so much fun. Okay.
Yeah, I think I got the concept this year.
Okay. I don't know if you're doing it, but for the sake of time, I'm gonna go ahead. If you're still trying to do it, just mute me. Okay? So, adrenal insufficiency. What is adrenal insufficiency? Adrenal insufficiency is when you have no aldosterone. Okay? And what does aldosterone do? Actually, wait, no, don't go. Try to solve it with me, like in the steps. Okay. What does aldosterone do? Do you remember? Aldosterone is in charge of sodium and water reabsorption. So if you don't have aldosterone, that means you do not have any water and sodium reabsorption. You don't have water and sodium reabsorption. You're losing sodium and water in the urine. Okay? You're losing water, which means your volume is going to decrease. Oh, for the Darianate, this is volume, and this is osmolarity. So if you go up, you're increasing osmolarity. If you go this way, or if you go this way, you're increasing volume. Okay? So you're losing water, so you're extracellular matrix fluid volume is decreasing, and you're losing sodium. So your concentration or your osmolarity is also decreasing. Okay? Now, here we said we lost osmolarity. Okay? So what's gonna happen? This means that there's a lot of water here. Wait. This means that the amount of water to solute here is too high, right? So what this is gonna do is it's just gonna move water to the other side. So now you have the same amount of water and solutes. Okay? Now, since you're moving the fluid from the ECF to the ICF, what's going to happen to the ICF? The ICF volume is going to increase. Okay? Now, all that's moving from the ECF to the ICF, this is one of the Deriana rules, you can only move water. So you're moving water, but the amount of solute is fixed. Okay? You're not moving any of these solutes. All you're moving is the water. Okay? What this means is the concentration here, or the osmolarity, is going to decrease. And this is your Derianate. And then, based off of this, if we go back to the options, what is it? It would be decreased ECF osmolarity, which is seen by the fact that this is down, and increased ICF volume, which is seen by the fact that the volume just increased. Okay? It went to the left in the ICF area. Next. Did that part make sense, by the way? I'm going to assume it did, and I'm going to move on. Okay. What hormone? Okay. Oh, you're here. Yes. Okay, alhamdulillah. If you have any questions, please do stop me. Could you try to answer this one? What hormonal response is triggered by hyperosmolar plasma? Okay. Hyperosmolar, can you try to relate it to just a term that we use more commonly? Like, if you're just walking after working out, would you go like, oh my God, I have hyperosmolar plasma? No. You just say, I'm thirsty. Okay? Because hyperosmolar is when you have more... Wait. Is when you have more solutes than water. Okay? So what are you gonna do to fix this? You're just gonna drink more water. What triggers you to drink more water? Thirst, being thirsty. Okay? So hyperosmolar plasma is just thirst. So what does it simulate? It simulates the hypothalamic thirst center. Okay? You can just go through these for why the other options are wrong, but I'm gonna skip it for the sake of time. And then once again, another one of my favorites, ECF ICF. Do you want to try this one? Do you want to go step by step? Okay. Now, we said that the patient has SIAD, or a syndrome of inappropriate antidiuretic hormone. Okay. What does this mean? It means you have excess ADH. Okay. What does ADH do? ADH normally is in charge of absorbing water in the distal portions of the nephron. Okay. So if you have too much ADH, you're going to have too much water reabsorption. And as we know from the Derianate rules, that any change would only affect the ECF. Okay, so you have too much water. What this is going to do is it's going to increase the volume of the ECF. Okay, now you have more water, or you have an increased volume, but the amount of solutes or the amount of particles, electrolytes, salts isn't changing. Okay, you're just increasing the amount of water. What this is going to do is it's going to increase the osmolarity. So across this line, we're going to go down, and then once again, you have a decreased osmolarity here. You have a few decreased osmolarity means you have too many particles, too little particles and a lot of water. Okay? What's gonna happen is water is gonna go from the ECF to the ICF. No. Like all of these will just go. Okay? Which is gonna increase the volume of the ICF. And then once again, because we're only moving water, we're not moving any solutes, we're not moving any salts or any electrolytes, this is gonna decrease the osmolarity of the ICF. So once again, decreased ECF osmolarity with increased ICF volume. Does this make sense? This way of thinking is why I actually enjoyed it so much. Like, I genuinely, you see these lines and how they go one by one. This is actually how I would draw them last year. And that's why I really, really enjoyed it. Okay? So I hope this technique helps. I hope it makes it easier and it makes it enjoyable like it did for me. Okay. Next. Could you try to solve this one? Which of the following, whoa, which of the following changes would be expected in a patient with Addison's disease? Firstly, what is Addison's disease? Okay, it's okay. It's all right. Inshallah, I'll remind you. Okay, the answer is A. Why? Because Addison's is when you have decreased aldosterone. Okay, what does aldosterone normally do? Aldosterone normally increases sodium chloride reabsorption, which in turn would cause more water reabsorption. Okay, so if you have decreased aldosterone, what this means is you're gonna have decreased sodium. Okay, decreased sodium in the body because you're not reabsorbing it, so it's all staying in the tubular fluid. Okay, decreased sodium and decreased water. Hala, what does decreased sodium do? Decreased sodium is going to result in increased potassium. Why? Because there's an NAK symporter, exporter, no, what was it called? Exchanger. There we go. And if you are reabsorbing less sodium, you're excreting less potassium. So this is going to result in increased potassium. Okay? And what's the decreased water going to do? Decreased water, which means your ECF or your volume in your body is decreasing. Okay, that's decreased blood pressure. And how does your body respond to decreased blood pressure? We said this in did we say this in the beginning? I think Aylin talked about it. You increase renin because renin angiotensin. I don't know if you guys did this in histo. I don't know if Dr. Annie showed you guys the video where just
a song.
Yeah, just a song. If she didn't show you, look up the renin angiotensin aldosterone song. It's a memory, honestly. Or if you want, I can send you a video of the lecture. It's really nice. Okay. Essentially, renin angiotensin, what it does, it's the whole concept. I don't know if you guys know this. Is it's there to increase your blood pressure. Essentially, it causes vasoconstriction. It's a vasopressin. Okay. So you have decreased water, which means your volume is decreasing. So we can just say hypovolemia. Hypovolemia means decreased blood pressure. How do you overcome decreased blood pressure? You secrete renin or renin, however you want to pronounce it. Okay. This is why your sodium concentration is decreasing because you don't have aldosterone to stimulate its reabsorption. Your potassium is going to increase because you don't have sodium to result in the excretion of potassium. Just NAK ATP. Think of it, most of the times, if I'm not mistaken, most of the times sodium and potassium go in opposite directions. Okay, because they're both positive and there's two gradients. There's concentration gradient and electrical gradient. So as a general rule, take it with a grain of salt because it's not applicable everywhere. If you're taking out something positive, you're going to be replacing it with something negative, with another positive thing. Okay, that's why sodium Na plus and potassium K plus are normally they normally go in opposite directions. Once again, this doesn't apply everywhere, but quite a few times it does. Okay, so increased potassium concentration because of the decreased sodium. Renin, we said, because you have less water. Less water is going to result in a reduced blood pressure. Reduced blood pressure is going to result in an increase in renin. Okay? And that's it for my part. Fireboy already got his diamond. Now on to Eileen's part.
Yes,
Sorry.
water girl can't wait to get her diamond. So let's start. Okay. Can I have the drawing device?
You can have the drawing device.
Thank you. Okay, first of all, I'm going to explain the concept and then move on to the questions. Because for this concept, for these few lectures, all the questions are exactly the same. They're just asking you about different measures, okay? If you understand the concept, خلاص, all the questions are going to look the same to you. So, first of all, I just want to talk about metabolic and respiratory acidosis and alkalosis, okay? So, when we say acidosis, what comes to your brain? Acid, like increased acid. So, this is an increase in hydrogen ions and a decrease in pH, okay? And then for alkalosis, it's the opposite. Your body is in alkaline state, so you have your pH increases and you have more hydrogen ions and less bicarbonate ions. So because bicarbonate is what causes, it's basic, okay? It's the opposite of hydrogen ions. So first of all, I'm going to talk about Rome after I explain the four things that you have to know. First of all, metabolic acidosis. So metabolic, whenever we say metabolic, you think about bicarbonate, okay? One second. Okay. Whenever you say metabolic, you think about bicarbonate, and whenever we say respiratory, you think about CO2. Because what does your lung do? it's excreting CO2, okay? So when you have a disruption in the CO2 intake or inhale or exhale, you're gonna have a problem. And then if you have also a problem in bicarbonate excretion or like you have less bicarbonate, you're also gonna have a problem. So first of all, metabolic acidosis. Acidosis, what did I say? Decrease pH. So increase hydrogen ions or you decrease the bicarbonate ions because bicarbonate is what is the alkaline molecule we have here. So when you decreases, you have less alkalinity. We have more acidity, right? So when we're talking about metabolic acidosis, you have a decrease in bicarbonate ions. Okay, so what does that do? It's gonna lead to, it's gonna, like in your body, you're gonna have acid accumulation. Not because the acid itself is increasing, but because the base is decreasing, you know? So it's relative. When you have two things that are the same concentration, but you decrease one, the other one, the concentration of it is gonna increase, okay? This is what they're saying here. A decrease in bicarbonate ions. It's gonna lead to acid accumulation. It's metabolic, so it doesn't have to do anything with the lungs, but there's also another concept that I'm going to talk about, which is compensation, but let me just talk about the alkalosis and acidosis first. Moving on to metabolic alkalosis, which is basically you have an increased amount of base, which is bicarbonate, due to loss of acid. That's what I'm saying. You're not increasing the bicarbonate, you're increasing the bicarbonate concentration because two things, same concentration, you decrease one, the other one increases. So when you're losing acid, you're losing H plus, and like relatively, bicarbonate is gonna increase because you're losing acid, okay? To respiratory, which has to do with the lungs, and nothing with bicarbonate, only CO2. And CO2 is what? Acidic, okay? So when we're saying respiratory acidosis, which it means that you have an increase in CO2 inside your lungs. And why is it acidosis? Because CO2 is acidic, okay? And then respiratory alkalosis, which is the opposite, a decrease in CO2. CO2 is acidic, so alkalosis, you have less acid in your lungs. Okay. For example, when you're very stressed and you're breathing so much, you're hyperventilating, okay? What do you mean by hyperventilating? You're taking out more carbon dioxide. So you're decreasing carbon dioxide, which leads to alkalosis. And the opposite is true. Hyperventilation, you're keeping in more CO2 inside your body. Your body is not excreting, or excreting is for urine, never mind. It's not releasing, you're not exhaling carbon dioxide. So it's gonna cause acidosis because CO2 is acidic. Is it clear so far? Because I'm gonna move on to compensation. Okay, so for Rome, it basically means respiratory opposite. So respiratory opposite and metabolic equal. What does that mean? See this first example. When the PCO2 refers to metabolic or respiratory? CO2. Respiratory. Yes, exactly. So when you're increasing CO2, what is this? Alkalosis or acidosis? Acidosis. And when you have acidosis, your pH increases or decreases? It decreases. Exactly. So what they mean by respiratory opposite is that when CO2 increases, pH is going to increase. And when CO2 decreases, pH is going to increase. That's what they mean by opposite. Dr. Angelica like put this at the end, and the ordering was just different, but this is the way where I think, I don't know, that's how I understood it, and that's how I understood it last year too. Even though we had a different doctor, but this is like this is the flow of thoughts, you know? And then for metabolic equal, it's basically saying when you have an increase in bicarbonate, you're going to have an increase in pH because bicarbonate is what? Basic. So increase in pH is going to go, it's going to be more alkaline, more basic. And the opposite is true. When you decrease bicarbonate, you're going to decrease pH because when you're decreasing the base, relatively, the acid concentration is going to increase. Okay? So one more thing that I have to mention is that when you have a metabolic acidosis or alkalosis, what's your body gonna do? Is it gonna leave you in the state where you have a lot of acid? No, it's gonna try to compensate. But it's not gonna compensate with the same system. Because for example, let's say you have defective lungs. If your lung is gonna compensate for the hydrogen molecules, it's not going to be able to do that because we said it's defective. So the compensation is usually with the other system. So when you have a respiratory problem, your kidneys are gonna compensate metabolic. And when you have a metabolic disorder or when you have metabolic acidosis, alkalosis, your lungs are gonna compensate by a lot of different mechanisms. But for example, when you have, let's just take this one here, respiratory acidosis, which is an increase in CO2 due to hypoventilation, because you're taking out less CO2. So it's acidosis. Your kidneys, what are they gonna do? They're gonna increase the reabsorption of bicarbonate. Why? Because when you have a lot of acid, you want a lot of base to buffer the excess acid, you know? And the opposite is for the respiratory alkalosis. When you're hyperventilating, you're taking out a lot of CO2. Your kidneys are what? They're gonna excrete bicarbonate. Because خلاص, you already are excreting a lot of CO2. So your kidneys are gonna excrete bicarbonate to reduce the alkalinity because you want to maintain the normal pH. Is this clear? Because I only have a few questions related to this, but because I told you it's the concept that's important, not like the questions, because all the questions are the exact same. Okay, thank you. Let's move on. Okay, clear all drawings. Okay. The first question I have here is a patient with severe diarrhea for 12 hours is likely to present with which of the following blood gas findings? Okay. Diarrhea is an example of metabolic acidosis. Why? Because when you have diarrhea, you're excreting a lot of acid. Okay? So when you're losing acid, what do you have in an increased amount? Bicarbonate or something that's basic. So, um, so that now that we know that diarrhea is metabolic acidosis, what did we say about metabolic acidosis? It's gonna have to do with CO2 or bicarbonate. If it's something metabolic, is it CO2 or bicarbonate? Don't you lose base in diarrhea? Oh, you do lose base in diarrhea. Hypermetabolic acidosis. Okay, thank you for correcting me. You're losing base. That's why we have acidosis. Well, I was confused too. Okay. Acidosis means that you're losing a lot of base, so the concentration of the acid increases. So what are we seeing here? Acidosis. Oh, I put for you the normal values for pH and bicarbonate and CO2, so you can use them as a reference. If you know these normal values, you can just solve any question. So because we know that diarrhea is a metabolic acidosis condition, acidosis is decrease in pH, so we're just going to eliminate the ones that have an increase in pH. And then it's metabolic, so your lungs have nothing to do with it. For the CO2 is just going to remain in the normal ranges. And then because you're losing base in diarrhea, your bicarbonate is going to be decreased. Okay, is this clear? And I'm very sorry for the confusion. Okay. Next question. A patient with suspected diabetic ketoacidosis has the following blood gas results. pH 7.2, carbon dioxide 30, bicarbonate 15. What's a primary acid-base disturbance and compensatory mechanism based on the results? Okay, A. See if it's A. Correct. Why is it A? Okay, I also put for you the normal values here. And by the way, when they give you, like, for example, a disease or something, if you can't remember what this disease causes, don't really like overthink it. The answer lies in the numbers. So here, pH is decreased. So what does this tell you? Is it acidosis or alkalosis? Acidosis, because pH is decreased. Ketoacid, so metabolic, so compensation respiratory. Exactly. But why did we say that there is There could be no compensation. Why did we say no? There's a compensation. What number here tells you that your body is compensating? It's a CO2. Yes, yes. Decreased CO2. CO2 based on the normal range, it is decreased. What does this mean? That you're hyperventilating, right? You're uh, exhaling more CO2. Why is your body exhaling more CO2? Because you're already in a state where there's a lot of acid in your body. So the mechanism, because it's a metabolic acidosis, the compensation is going to be with the opposite system, which is your lungs. So because there's a lot of acid in your lungs are going to excrete more acid to compensate for the acidity. Is it clear? And whether you can see here that the bicarbonate is decreased. Yeah, okay, clear, thank you. Next question. See how like all of them are the exact same thing, you just have to know the numbers and so inshallah you're good to go. Okay, so U dot says B. Let's see. It is B. Why? Okay, let's analyze it. pH is 7.3. Is this acidosis or alkalosis? It's acidosis because it's decreased. And then bicarbonate 14, which is also decreased. And then PCO2 is 18, which is also decreased. So what is the body doing? When you have, it's a metabolic acidosis because as you can see, the bicarbonate is the one that's like decreased. And then why is PCO2 also decreased? Exactly, the bicarbonate decreases, so metabolic CO2 decrease compensation. Your body is basically, this is like very similar to the question before, but in another way. They're asking you what the compensation was because your body خلاص has already enough acid in your like enough acid, so it wants to expel acid in a way or another. So when you increase respiratory rate, which is hyperventilation, you're gonna increase CO2 exhalation. This is how your body compensates. Is it clear? Compensate for the metabolic acidosis. Yes, thank you. Okay, I think this is plus we're reaching the end of this. Do you think the answer is? Okay, the answer is A. Why? Because as let's just analyze the numbers one more time. 3.2 pH acidosis, bicarbonate is 30, which is increased, and then PCO2 is 55. Okay? What compensatory response is responsible for the elevated bicarbonate level? Okay, so we saw that PCO2 is very, very high. It doesn't, it's يعني very high indicates that it's acidosis. Okay? Yeah, it is combined, but by the process of elimination, renal retention of bicarbonate. So if you have acidosis, you need bicarbonate. You need something to buffer that extra acid. So your kidneys are gonna reabsorb the bicarbonate. Retention means like you're reabsorbing the bicarbonate. Why do you want more bicarbonate? Because you have a lot of acid. So you're yes, you're buffering the extra acid. Okay. So I just there she added your doctor added two graphs and I'm not gonna really explain them, but I just put it here for the sake of completion because if I were to put a question on it, صراحة I would be just recall. I put for you like the points what they indicate, and for example like here they can ask you Someone presented to the clinic and with severe vomiting. Blah, 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 blah. What point in this diagram would you think his case would be? Severe vomiting. Oh, yeah. Okay. Severe vomiting, that's when you lose acid. Diarrhea, you lose base. Vomiting, you lose acid. So the point is going to be B, for example. Okay? Metabolic alkalosis. Because you're losing a lot of acid. That's how the questions are going to be. Okay? Okay, we're gonna move on. This is the last question. Which of the following conditions is most likely to cause an elevated anion gap in a patient with metabolic acidosis? Okay, B, correct. Why B? Okay, let me go to the concept of the anion gap. Because acid is added, exactly. This is the equation for the anion gap, and it basically just tells you, it measures the concentration of ions you have in your body. And whenever you have an elevated anion gap, it's basically because you have an accumulation of unmeasured anions, which is in the previous case. Okay, and some of the examples are diabetic ketoacidosis, lactic acidosis, or poisoning. And then when you have a normal anion gap, for example, when you have diarrhea, your body is going to compensate by increasing chloride. It's when you have a normal anion gap, it's not because everything is normal in your body, but because your body is compensating by increasing chloride, which is called hyperchloremic state, because you're losing bicarbonate, and it's compensated by increased chloride. Okay, and this is seen in diarrhea and renal tubular acidosis. Is it clear? Okay, thank you. Okay, we reached the end of our past session.
Okay. Thank you so much, guys. I hope this was beneficial.
Inshallah.
Obviously, the best thing you can do is just make lots of dua and do your best. At the end of the day, nothing, Allah ما حدا يتعبكم. Whatever you do, you will be rewarded for, inshallah.
And trust yourself, Loki, wallah.
I hope this was
You're welcome.
beneficial. You're so welcome. I really hope this was beneficial. And if you have any questions, feel free to reach out.
And obviously, I'm going to promote my tidbits. Stay tuned for the tidbits. Inshallah, we put a lot of effort in it. Inshallah, it's going to be given to you as soon as we can.
Yes, inshallah.
Tomorrow.
Tomorrow, inshallah. Don't forget to scan the QR code for any feedback you have. And if you have any questions at all, feel free to reach out. Also, one lecture, the 12th physiology lecture, we did not add any questions because, yeah, past papers. Just past papers. Okay? There was no point in adding it, and it would have just taken up a lot of time. So just make sure you use the past papers. And
Inshallah.
oh, the one question, there was a question in the back where I was like, I don't know what happened. It was a technical issue. Just forget about it. It was a wrong question, so I just forgot to delete it. Other than that, thank you so much.
Thank you guys so much.
I hope this was beneficial. Best of luck. You got this, inshallah.
Thank you. Bye.